Thank you for staying to the end of the presentation on such a beautiful day. It's an honor to be here. I would like to thank Dr. Desmond and Dr. Corden for the invitation. It's a real privilege to be able to present along with so many distinguished speakers, and with that, the paparazzi downstairs. Also, it was quite unexpected. So I will be presenting on cutaneous toxicities associated with targeted therapies. These are my disclosures. As a matter of background, of the 1.6 million people that are diagnosed with cancer in the US every year, approximately 45% of these individuals will have some type of dermatologic condition even before they start their treatment. These conditions include tinea pedis, onychomycosis, cirrhosis, pruritus, and bacterial skin infections. Of these 1.6 million people, approximately 900,000 will receive chemotherapy or a targeted therapy, as was just described by Dr. Friedlander. Approximately half will receive radiation, and most will have a surgical procedure as part of their diagnosis or treatment, all of which can invariably result in dermatologic adverse events. So what are the consequences of these dermatologic events? They are considered to be fourfold. They have a psychosocial impact because they affect areas of the body that are exposed to other people, and people feel they lose their sense of privacy because people ask them what's wrong with them or what disease they have, and they have to disclose they have cancer at work or to their children or to their friends. They also carry a financial burden. We all know the cost of medications in cancer. Now we are adding also medications to treat dermatologic events, which frequently are not covered by many insurance carriers. And something we've had to convince oncologists about is that they carry an effect on physical health, because many of these conditions, as you will see, can be painful, in which affect a person's ability to perform their activities of daily living, or can lead to serious infections that require IV antibiotics or hospitalizations. But the most important consequences of these adverse events is that they can lead to inconsistencies in dosing of the anti-cancer therapies, which may affect clinical outcome in a negative way. So as Dr. Friedlander just described very eloquently, there are a variety of pathways and proteins that are dysregulated in melanoma, and based on these observations, several small molecules or monoclonal antibodies have been approved that are able to block these pathways that are dysregulated, reverting to a benign or controlled phenotype. Similarly, this has been the case for basal cell carcinoma, and an unapproved agent based on the observation that cutaneous squamous cell carcinomas overexpress the epidermal growth factor receptor inhibitor. One could also use in an off-label fashion agents that block the epidermal growth factor receptor, such as cetuximab or erlotinib. But whereas an oncologist sees these pathways and proteins as a therapeutic advantage, we as dermatologists should see this as that they are targeting the skin, because those same pathways or proteins that are dysregulated in malignancies are also critical for the normal homeostasis and functioning of the epidermis, the dermis, as well as the immune system that populates the skin. And consequently, if you block any of those proteins and pathways, you will see that patients will develop a constellation of dermatologic adverse events that are consistent between the targets that are being blocked and do not depend on whether the drug is a monoclonal antibody or a small molecule, but just on what type of target is being blocked, as you can see here. And what is the most common dermatologic adverse event that has really led to an increasing attention to the field of what we have called oncodermatology? This has been the acneiform rash that was first seen with epidermal growth factor receptor inhibitors. This drug is a pathway-dependent event that occurs with drugs such as afatinib and erlotinib approved for non-small cell lung cancer, or monoclonal antibodies such as cetuximab, which is approved for head and neck cancer as well as colon cancer. In addition, the MEK inhibitor trametinib, as was discussed previously, approved for melanoma, will also result in this acneiform rash in about 60% of patients, being severe in about 10%. This rash can be associated with pruritus and tenderness in about 2/3 of patients. And importantly, it appears explosively within the first 2 to 4 weeks of therapy, and it is the number one reason as to why these patients have their drugs interrupted or discontinued in about 1/3 of cases. This is another representation of a patient treated with the monoclonal antibody cetuximab. So why these patients, and so many of these patients develop this acneiform rash, is because, as we all know, the epidermal growth factor receptor is abundantly expressed in the epidermis and the outer root sheath of the hair follicle, and its inhibition results in a downstream inhibition of the EGFR pathway, as has been demonstrated by Bea Nardone from Northwestern. What Bea did is that she analyzed with several downstream markers, such as phospho-AKT, the skin of patients treated with several of these inhibitors. And what she found was that with agents that block the pathway more potently, leading to greater rash, you also saw a greater downregulation of phospho-AKT, as is seen here, indicating that this is a mechanism-based effect. And a paper published in 2013 from Peter Gerber from Dusseldorf also showed that this is more of an inflammatory event. What Peter showed was that in patients treated with erlotinib, by analyzing for the inflammatory infiltrate, as you can see here, a mixed inflammatory infiltrate with immunohistochemical stains for CD1, for CD68, CD4, and CD8, you can see that there is an abundant infiltrate of these cells in the pustular lesions of these patients. Furthermore, he stained for chemokines and compared control skin, as seen here, that was negative, to the skin of patients treated with erlotinib. And what you can see here is that there is upregulation of a variety of chemokines, including CCL27, CXCL14, as well as CCL5 and CCL2, demonstrating perhaps that an anti-inflammatory agent would be efficacious against this rash, and in fact, the use of topical corticosteroids and oral tetracycline agents have shown benefit in mitigating this rash. Another important observation that highlights the importance of the epidermal growth factor receptor pathway in skin homeostasis is that we had noticed that a number of these patients developed secondary infections in the skin. And what he demonstrated in vitro was that in the, when you treat epidermal keratinocytes with erlotinib, you see that there is a greater growth of Staph aureus, as seen here, indicating that inhibition of the epidermal growth factor receptor has a direct immunosuppressive effect in skin, something that also has been demonstrated with the MEK inhibitor trametinib. And he was also able to demonstrate that here, showing a dose dependency in the degree of immunosuppression in skin, demonstrating why up to a third of patients treated with these drugs develop second superinfections after they develop skin toxicities. But not everything related to the inhibition of the epidermal growth factor receptor is negative. We do know that cutaneous squamous cell carcinomas do have a somewhat similar biologic behavior than head and neck squamous cell carcinomas. They follow a similar lymphatic spread, and they also have a similar 5-year survival when they are advanced. This figure illustrates the expression of the epidermal growth factor receptor of a patient with advanced SCC. So based on these observations, a number of investigators decided to use agents approved for lung cancer or colon cancer for patients that were not amenable to other therapies for cutaneous SCCs, such as in this 92-year-old patient, which presented with this large tumor here. The patient was not amenable to any other therapies. Therefore, the patient was treated with cetuximab, which is the monoclonal antibody administered biweekly. And what you can see here, it was that there was a complete resolution of the lesion, and there was a response that lasted for up to 7 months. Subsequent to this, a variety of other investigators have also reported cases, including one phase 2 study in which 36 patients were treated and showing a variety of responses, most of which were positive. And in summary, based on what had been published up to last year, 54 patients in the literature have been reported with advanced SCC of the skin, in which the administration of an EGFR inhibitor led to stable disease in a third, partial responses in a quarter, and complete responses in about 20%. Also interestingly, the toxicity profile of these agents is relatively benign compared to other agents that are used in this setting. Moving on to a different agent, Dr. Friedlander spoke about agents used against melanoma. So one must speak about vemurafenib, which was the first agent that was introduced. What is notable about vemurafenib is not only the way that patients respond very quickly to it, but also its great toxicity. About half of these patients develop this maculopapular rash, which is again explosive within the first 2 to 4 weeks. associated with intense pruritus, and patients get extremely scared because of this rash. Biopsies show a nonspecific inflammatory infiltrate, and interestingly, the rash, although it appears more of a hypersensitivity, if you interrupt the drug, treat the patients with oral corticosteroids, and re-challenge them at a lower dose, the rash does not seem to reappear, which goes against everything that we learned from the textbooks about maculopapular drug hypersensitivities and patients not being able to receive these drugs. In this setting, because we don't have the luxury of other drugs, we have learned this kind of novel observation. Similarly, with the agent dabrafenib, what you see is a different type of rash. It turns out that these drugs block mutant BRAF, but they cause a paradoxical activation of wild-type BRAF. In other words, BRAF everywhere else in the body, especially the skin and other epithelial tissues. So what you see is that these patients with therapy after 2 months or so develop this proliferation of the skin. They develop this very thick skin with keratosis pilaris and palmoplantar hyperkeratosis and a variety of other proliferative lesions that I will show you later that are reminiscent of these inherited syndromes that are characterized by activating mutations of BRAF, such as Costello syndrome, which is a type of cardiofacial cutaneous syndrome. So keratosis pilaris here, I am one of the believers that if it looks like a certain way, you treat it a certain way. So you treat it with topical alpha hydroxy acids or urea or salicylic acid, etc. It's something that really does not lead to dose modification, yet it is an interesting clinical observation. Because these changes are also evident in the palms and soles especially. You can see here this palmoplantar hyperkeratosis, which has been called also a type of hand-foot syndrome, is present in about 60% of patients treated with vemurafenib, to a lower extent with dabrafenib, but there is a new agent from Novartis that is currently under investigation known as encorafenib, and these calluses or hyperkeratotic plaques in the feet are so severe that patients sometimes come in wheelchairs because they literally cannot walk because of the intense pain in these areas. So I refer patients in many instances to podiatrists, use salicylic acid, urea. Also topical lidocaine or lidoderm patches are useful, I found. But essentially it requires a lot of therapy and continuous therapy of peeling these areas, recommending for patients to shave these. I found myself shaving these calluses of patients in the office, and that really is what is required in this case. As you can see here, histology shows that there is a hyperkeratosis of the stratum corneum, and it is just an effect of the paradoxical hyperproliferation of the skin, which can be a more significant problem if there are associated RAS mutations. It also turns out that, as Dr. Friedlander mentioned before, about 20% of patients treated with vemurafenib or dabrafenib will develop secondary cutaneous squamous cell carcinomas, most notably keratoacanthomas. You can see here that they appear in multiple lesions in about a third of patients, and they occur at about 6 months or 2 to 4 months of therapy, with a median of about 6.5 months. These lesions differ to that which you have seen from patients that have received solid organ transplants, because these lesions appear very rapidly within the first 2 to 3 months, and many lesions appear simultaneously. Because so many lesions appear and the benign histologic pattern that they have, the treatment for this is usually relatively benign in the sense that we don't do Mohs surgery for each one of these, and in many of these we just perform suturization of the lesions in order to minimize the morbidity associated with treatment and to minimally impact the patient's quality of life. And in addition to that, from an analysis that we conducted in over 110 lesions, you can see here Dr. Raj Margoob, which is my colleague at Memorial. We try to identify which features would allow us to identify, because of the multiplicity of these lesions, those that were benign versus those that were malignant. And what we found was that there were certain characteristics that we hope to educate the oncologists that see the majority of these patients that would prompt a referral to a dermatologist. And as you can see here, most of these lesions that were associated with malignant features are those that were larger in size, had a nodular shape, as expected, had a keratin plug with scale or an ulcer, and had a red halo or a scaly ring. And these factors were also associated with malignancy, along with a history of a cutaneous SCC, the use of vemurafenib, and a pre-existing melanoma. In addition to this, and even more concerning, is a study conducted by Stéphane Dahl's group in France. What they did is that they followed 42 patients on vemurafenib, with digital dermoscopy. The total number of patients that they followed was 42 patients with about 51 lesions per patient. So this added up to over 2,100 lesions that they followed dermoscopically every month. So this tedious study that they conducted was very productive because, as you can see here, what they found was that 56% of these lesions had changes, most notably changes in color, the number of globules, and these changes were all over the place. As you can see here, this is in percentage of lesions and timeline. You can see every month there was a variation in terms of the appearance of these lesions that changed in terms of color, globules, or other features. Of these lesions in these patients, 36 were excised, and there were 14 melanomas, so 1.2% of these lesions were melanoma in this patient population. This figure illustrates the change in these lesions. You can see these are patients at baseline, month 0, month 4, and month 10. You can see here how striking changes occur in these lesions throughout time. Sometimes these patients have so many lesions that it is just impossible to remove every single one of them, and one just has to choose which is the one that has the most malignant features. Furthermore, on histology, what you see is also the striking alterations in which the cells have this very rapid pagetoid spread, as you may be able to see there. And also you can see that because of the paradoxical activation of BRAF, there is an upregulation in phospho-ERK, phospho-AKT, as well as CD1. Another complication of the use of vemurafenib is the severe photosensitivity. Patients say that only after a few minutes of being exposed to the sun, they can develop blistering sunburns. This is a patient that was treated with vemurafenib, as you can see here, and also another agent that is used in the oncology setting that has a similar phototoxicity is vandetanib, which is an EGFR and PDGFR inhibitor. What is notable about this phototoxicity is that it is exclusively limited to ultraviolet radiation A, as demonstrated here. So many of the oncology patients and the oncologists do not know the differences between UVA and UVB, the fact that they can get sunburned while being indoors or in their cars. So one has to conduct a lot of educational measures in these patients in order to maximize their quality of life. Similarly, another type of radiation that causes greater toxicity when vemurafenib is being used is gamma radiation. This is a patient that had brain mets and was treated simultaneously with vemurafenib along with radiation. You can see here that this caused a severe edema of the scalp with disappearance of acutis verticis gyrata and intense pain. Caroline Robert from Paris also showed that there was an increased radiosensitivity when vemurafenib is used in conjunction with radiation. So based on these observations, the recommendations are that do not use vemurafenib simultaneously with radiation, and some of you may know the only studies that have shown to be positive in the prevention of radiation dermatitis are with the use of topical corticosteroids of high potency, such as mometasone, and topical antibiotics such as silver sulfadiazine or Silvadene. And again, I want to show also the positive part about these drugs in the dermatology realm. It turns out that a group of investigators from France also found that there were BRAF V600E mutations in patients that had Erdheim-Chester disease in about 54% and in about 40% of patients with Langerhans cell histiocytosis. This is a biopsy of a patient that had Erdheim-Chester disease, and what you can see here is using the VE1 antibody, the abundant expression that is noted with the pink stain. And as Dr. Freelander showed before, when patients with Erdheim-Chester disease, these first 3 patients were treated with vemurafenib at the standard dose of 960 milligrams BID, you can see that after only 1 month, there is a significant decrease in uptake in this PET scan. And this response is durable, is maintained, and it seems like patients that have BRAF mutations from other tumors respond differently than patients with melanoma. We currently have what is called a basket trial ongoing, which means that patient that has a cancer with a BRAF mutation of any organ in the body receives vemurafenib. And what we have found is that converse to melanoma, which usually becomes resistant at about 6 months, patients with thyroid cancers, lung cancers, and these histiocytoses that have a BRAF mutation can have a durable response of up to 3 years of vemurafenib. And you can see here, these improvements in LCH were also documented histologically with, as you can see here, the skin manifestations were completely abrogated after 1 cycle, and these were confirmed histologically with the expression of CD1A, and also with the VE1 stain was completely abrogated at 1 month. This is one of the patients that I follow at our institution. You can see here, this lady actually was featured in a story in the New York Times several months ago based on this whole notion of these basket studies, that it doesn't matter really anymore what tissue the cancer is from, but rather what mutation it has, and therefore the therapy should be directed as was described earlier today as well. You can see this patient at baseline with the skin involvement after only 2 cycles or 2 months of vemurafenib. There is complete resolution of these lesions. Dr. Freelander also spoke about immunotherapies, so agents that block CTLA-4, ipilimumab, or agents that block PD-1, nivolumab and pembrolizumab. What you can see here is that with these agents, you see also these immune-related adverse events. Most notably, you see a maculopapular rash that is extremely pruritic, and the histology may show a lichenoid infiltrate, as you may be able to see here, with some vacuolization of the basal layer. But interestingly, these patients also develop this severe pruritus that is not characterized by a significant infiltrate and almost no skin findings to the naked eye. So the treatment is relied on oral antihistamines, topical steroids, and with also what we have found to be effective anecdotally and also has been studied in the cancer population is the use of the NK1 receptor inhibitor aprepitant, which is a drug used for the prevention of chemotherapy-induced nausea and vomiting. Other immune-related adverse events include type of vitiligo in these patients. As we know, these drugs activate the immune system or unleash the immune system. And what we can see is that, interestingly, about between 4 to 10% of patients treated with these drugs will develop a type of vitiligo. And for some curious reason when it involves the hair, it usually involves the hair, as you can see here, on the crown, and it also involves the eyelashes and the eyebrows. Another observation that is different that may yield additional insight into dermatologic disease is that patients that are treated with these drugs that unleash the immune system appear to have these lichenoid disorders. For example, a group of 3 patients reported from Mayo Clinic showed that these patients had a lichenoid rash, as you can see here, with the characteristic clinical findings. And when histology was obtained, you can see here, there was an infiltrate characterized by CD3 and 4 expression primarily. Also, interestingly, there was PD-1 expression that was decreased in the skin. Another observation that we have found, we have currently 4 patients that have presented for what has been referred to by the oncologist as mucositis. Upon closer observation and in collaboration with Vincent Sibat from France, what we have been able to describe in a paper that is currently under review is that these patients what had is something somewhat similar of oral lichen planus, as you can see here, with the characteristic lichenoid infiltrate, as you can see here. And interestingly, these patients respond very well to topical therapy with corticosteroids. Similarly, other autoimmune disorders of the skin can be seen. 3 cases of bullous pemphigoid have been found that you can see here with patients treated with nivolumab or pembrolizumab. Developed these blisters that occur mostly in the trunk. We have seen also some patients that develop these blisters in the mouth. Direct immunofluorescence and histology also recapitulate these observations. And interestingly, in every patient that we have seen these autoimmune blistering disorders or severe disorders, they appear to have a better response. And this is something that has been demonstrated with EGFR inhibitors, for example, is that people who have a worse toxicity respond better to the drugs in terms of their cancer. This is one of such patients. This patient had metastatic non-small cell lung cancer. You can see here, after several cycles of the drug, there was complete resolution of the lung metastasis that was concurrent with his blistering disorder. And finally, something that we forget to tell patients when they are receiving these so-called targeted therapies is that patients think that because these are not conventional cytotoxic agents, they are devoid of many of the toxicities, such as alopecia. It turns out that one of the top reasons why patients will stop vismodegib and sonidegib for advanced basal cell carcinoma is because they develop this partial alopecia, which is very difficult to treat, and sometimes I feel it's permanent from the patients that I have seen. The incidence of alopecia to these targeted agents for cutaneous malignancies, as you can see here, ranges between 10 to 30%, depending on the agent. And what you see here is these empty hair follicles that are very interesting and unlike any other types of alopecia that we have seen. So to conclude, cancer therapies have an important effect on skin and hair. Dermatologists play a critical role in evaluating these patients because we can identify new toxicities as well as perhaps learning about other dermatologic conditions. I believe that these dermatologic adverse events will increase in importance as these drugs enter the adjuvant setting, so patients will be healthier and they will be less willing to tolerate these adverse events. When drugs are combined, as was mentioned previously, combining ipi and nivolumab leads to a severe rash in about 45 to 50% of patients. And as patients live longer, the silver lining is that as patients live longer, they are more worried about these quality of life issues. So if you want additional information on this topic, there is a book that there are many co-authors in this audience that contributed to, which is based on dermatologic care in the oncology patient, and that is listed here. So to conclude, I think if I have accomplished my mission, now all the members of the audience are experts in dermatologic adverse events to cancer therapies. I would like to conclude with a question, and I think that by now I think everyone is nodding, so you all know the answer. So to the left, what you see is that this is hand-foot syndrome induced by vemurafenib, and to the right is Roger Federer's tennis calluses. Thank you very much.